Good afternoon, everyone. Thank you for joining us today. We're very excited to have you join another SimiTree webinar. If you have any questions, feel free to use the Q&A as we go through this webinar. I'm going to post the handout into the chat here in just a minute. I'm Missy Gilliland, the Director of Learning and Development here at SimiTree, and we're really glad you could join us. We have some of the best experts in the business here today to talk to you about analytics for IDD providers. So I'm going to turn it over to Melanie to get us started.
Great, thanks, Missy. So the agenda for today, we're going to go through just a few things. First, we'll introduce the two of us, so myself and Jennifer. Then we'll talk a little bit about some of what we think are the critical KPIs for IDD organizations, and probably it extends to kind of almost all healthcare organizations as well. We'll talk a little bit broadly about what analytics is and how it applies to our industry. We'll talk about how analytics can help organizations kind of optimize those KPIs and use those. And Jennifer is going to bring some really nice case examples from her organization, Am Boundless, to bear, and kind of let us know their journey and how they came to be using the analytics and what they learned from them. We'll also help you at the very end, just kind of summarize everything we talked about during the presentation and figure out where you guys are on your journey and how you can build your own analytics roadmap. And then at the end, we'll have Q&A. But as Missy said, if you have any questions, just feel free to drop those in the chat. If there's a clarification question, Missy can stop us and let us know, and we'll clarify. Otherwise, we'll just kind of wait till the end. So first, we'll give our introductions. So I'll let Jennifer introduce herself first.
Thanks, Melanie. I'm Jennifer Riha, and I do serve as the Chief Strategy Officer for Boundless. I do have about 15, maybe a few more, years of experience in behavioral health and intellectual and developmental disability, and then also in autism care. And I think that one of the reasons I'm most excited about today's presentation is because I absolutely started from ground zero, maybe even negative numbers, if that's possible. And so to be able to be here today and be talking about the progress that we've made and all the things that I've learned along the way is really exciting and really an honor. And so hopefully there's some lessons learned, maybe even some mistakes to avoid that other people can take from our journey. So thanks for having me today, Melanie.
Thank you so much. And I have to say, from working with Jennifer and the team, they're quite amazing, and we have learned quite a lot. So I'm Melanie Elliott. I am Vice President of Analytics Strategy with SimiTree. I have over 2 decades of experience in behavioral health with the gamut from all the way from mental health and SUD to IDD. My expertise primarily is building standardized and flexible data warehouses, but my passion comes from measuring client outcomes, evaluating progress, and really answering all of those critical industry questions to not only keep organizations afloat and successful, but also to make sure that we can also respond to payers and know that what you guys are doing really makes a difference. And just a note or two about SimiTree, for those of you that haven't heard of us before, we are a consulting agency on both the behavioral health side and post-acute side. So almost the full continuum of lifespan care. And we provide everything from consulting services, including EHR and other source-related vendor selection to implementation of those particular systems, as well as a whole breadth of consulting, outsourced billing, RCM, and then of course analytics. And analytics came from the acquisition of Afia Analytics about a year ago. And sort of that's where I came from in my history and how we joined. So what we're going to be talking about and kind of showing examples of is with Jennifer's use cases is the product line that we have of the analytics, everything from just the base that you can get from your EHR, and we'll show you how you can use it for all of the different sources and other pieces of data that you need to grab and use. So what we now want to do, now that we've introduced ourselves and SimiTree, we'd love to, and actually, Jennifer, feel free. I know you didn't get to tell too much about I Am Boundless, so maybe sprinkle that in if you'd like to, kind of as you go through, or do you want to do it now?
I'll be happy to share as we go through and talk about some of the stories. Thank you, though.
Perfect, perfect. So Jennifer and I were thinking, what are some of the critical KPIs for IDD organizations? And I hinted to this earlier. This is not unique to IDD. It's honestly, pretty common across healthcare. So Missy, if you want to go to the next one, we'll take a look. There's kind of three broad categories that we thought the KPIs are really critical for. One being revenue, of course, getting those monies in the door and growing the organization so that you can serve more individuals. So two of the questions that we thought there that were really important and really kind of, went along really well with the case examples that Jennifer's had in her journey with I Am Boundless is, are we getting paid what we should on those contracted services with payers? So when we have that fee for service, there's a contract rate. Are we actually getting those money in the door? So that's really kind of a net collection question, and has a lot to do with kind of the billing processes within the org. But then there's another question of, if you guys have IDD waivers or other types of, authorizations, are we actually recouping every single dollar that we can, or are we leaving money on the table, which means there's also services and resources that our clients aren't receiving? So kind of two really interesting questions there with revenue that we'll talk about. And then moving on to costs. So if you think about revenue, right, that's kind of like payer reimbursement. But cost is really, how much does it cost the organization to provide the care that they do? So do we know what it costs for us to provide the care to all the populations we serve? Because some of you guys are not just IDD, you are a little bit broader than that. And even within IDD, there's a lot of subpopulations. And then, of course, what's the profit margin and how might that change? So if payers are going to change their rates or their requirements for payments, do we know how that's going to impact us? So that's kind of a really important question to be able to answer what's going to happen in the future. And then, of course, client outcomes. We're always interested in making sure that we can show and prove that clients are receiving not only the appropriate level and type of care that they need, but at the appropriate medically necessary or even optimal frequency. And then, of course, our clients obtaining and maintaining positive outcomes as a result of that care. So are we actually seeing them improve? So those are, kind of three areas that we thought were really important. Jennifer, anything you wanted to add to those?
Yeah, if I could, these really were the questions that prompted us to start on this journey. So, Boundless, as you alluded to earlier, is an organization that it has a long history, really originated out of being a intellectual and developmental disability services provider, primarily residential and primarily adults in one county in Ohio. However, over the past 7 years, we've really grown and diversified and expanded, not just geographically, but also how we think about ourselves and the range of services that we provide. So we now serve over 5,000 people across the whole state of Ohio, and do everything from behavioral health care to primary care and sort of your ancillary health, occupational and speech, dental services. We still do lots of residential. We have school-based programs, day programs, and as we've made those transitions, these were the original questions that we started with back in around 2018, 2019 of really, it was, what does it cost us to provide care? If we're going to expand, if we're going to evolve, if we're going to diversify, we need to know that we're making good decisions. So we need to know that we're going to stay in business if we do these investments in growing. So we needed to understand, what does it cost us to provide the services we provide now? Are there things that we can learn from that we can apply as we want to start new business lines, new service lines? And then being really efficient around making sure we are getting paid every dollar that we should be, that we're recouping everything that our contracts say that we should, that we're maximizing and being really efficient and proactive about waivers, that if people are supposed to be getting a certain number of services, making sure that we have the staffing to deliver those services, that we're able to bill all of those services. And then obviously the mission side of it, of making sure that we could measure and show that we're doing really good quality care that makes a positive difference and impact on people's lives. And so these questions right here were literally where we started of we feel like we need to know the answers to these in order to be able to grow and to even understand what the direction of our growth should be or could be. So our story really started with these questions, and then we put out an RFI, a request for information to lots of different vendors. Ultimately, long story short, found a FIA, selected a FIA, which then became SimiTree, and really have been on this path answering these questions and building on those over all of these years since then. So I feel like this sort of takes me back to where it all began, and I think for most providers, these are the key questions of, are we maximizing revenue? What does it cost me to deliver a service? Am I getting paid more than I'm, spending on delivering these services? And can I do something about that? And I'll tell some stories here later on where once we started to be able to answer these questions, we were able to take this data and actually use it in conversations with payers to maximize and in some cases even increase the amount that we were able to get paid because we could then tie it to these outcomes that we're talking about. So I could not agree more that these really are the most critical questions to focus on. um, and it's funny because when we started with these questions, we thought it was going to be easy to answer these. These are the first three. Like, we'll quickly sail through these and move on to more complicated and sophisticated things. Well, we're still answering these three on a regular basis. So give yourself some grace.
Yes. Oh, very good point, Jennifer. Yeah. And like you said, it's absolutely a journey even within each of these, because as you guys know, even per payer, right? It's a journey, like, per contract, per county, even, so yeah, absolutely. So I love that you said give yourself grace, because most definitely they surely should. Missy, if we'll move to the next one, I think what we're going to do is talk to you guys a little bit about analytics. This may be a touch basic for some of you, but I just like going back and going over it, especially kind of what is analytics, because I think of it, and I think our industry thinks of it a little more broadly than kind of some of the original definitions. So on the next slide, we'll talk about the definition. So we actually grabbed the definition from Oxford Dictionary. And it says analytics is information resulting from the systematic analysis of data or statistics. Well, that sounds really academic, right? Kind of this is my layman's definition that I put on here, because now analytics kind of encompasses, it's like all of the data across all of your data sources that you use to answer questions, evaluate progress on KPIs, take action, like Jennifer was saying, based on what the data is telling you in order to improve future performance. And that's going to vary widely amongst all of you, right? Some of you guys may have business intelligence already and you've got it in one place. Some of you may have it in multiple sources that are spreadsheets and you're culling it all together and trying to make sense of it. It might be a lot of manual effort, but all of those efforts that you guys are utilizing to get the data from the data sources, to make sense of it and use it to make decisions, that's really all of it is analytics. It truly is. What we'll be focusing on in this one is kind of like more optimal in terms of like what we have in terms of the system. But again, it's a journey. So, we'll see where you are and how you get there on the roadmap. So where does the data get entered that we use in analytics? So we'll look at the next slide and we'll see that there's a bunch of places that we have data in healthcare, right? The EHR. Now you guys might even have more than one EHR. I know I Am Boundless does, because they utilize, certain ones for ABA and other, and another one for their primary, other sources. And they're trying to cull them together and get all the, everything in one, but it's hard. Sometimes, you're used to what you've been doing, and sometimes the optimal one doesn't do it the way you guys need it. So sometimes there's more than one electronic health record. Health information exchanges. Luckily, more and more the states are increasing the amount of data and the quality of the data in the health information exchanges. And so if you have the opportunity and you're in a state with an HIE that has, information for hospital admissions and discharges, ED visits, and even if possible, which Ohio has a wonderful HIE that actually has lab values and vitals and some other wonderful things. That's another rich source of data that you can see when individuals are seen outside of your organization. Where are they going? What's happening to them? How critical are the things happening to them? So that's a really nice, rich source of data if you can grab access to it. The general ledger, of course, if we're talking about, finances and revenue, a chunk of it's in your EHR, but then you're obviously closing it out and making sense of all of it, especially with your cost in your general ledger. Most often we grab general ledger data on a monthly basis at the close of business through the, trial balance or an income statement. Also, another rich source of data is your HRIS system or your payroll system, because it gives often, work hours. So if some of you are traveling or calculating hours and time traveling, which is really nice, right? So you're able to get that. You're able to get payroll information. Say you're on a biweekly payroll schedule. If you want to know the cost of a provider for providing care, having their payroll tells you a lot of information in terms of that cost. The other places that we have data, of course, are smart sheets or spreadsheets, that are out there that individual providers are using, or program directors or somebody else is using to collect information. There's also state portals, some that we have to get data out of, but most of them we're required to put data into. And so sometimes you have to deal with, is there duplicative data? Or is that your only source because you don't have time to enter it 2 times? So there's a lot of different things to think about of where your data gets entered. Is it your only copy or source of that data, and how to utilize it? Jennifer, anything you want to add to the sources?
The only thing I would say is, again, I think I started out thinking, oh, well, it should be relatively easy to figure out the answers to these questions. But as Melanie is pointing out, one of the big steps in this is figuring out where is the data already being entered? Is that the only source of truth? And if there might be 2 places that could be a source of truth, either selecting one that you're going to say, this is the one that we default to if there's a difference between them, based on this sort of decision-making process. And then the other piece being, I like and appreciate that you called out smart sheets and spreadsheets, because the reality is, especially in the IDD space, there are still a lot of scenarios where information is entered into spreadsheets, or the only information that we can get out of a state portal or maybe some sort of outcomes tracking system is in Excel. And so what do you do with that? It's not very fancy. How do you turn that into analytics? How do you match that up with payroll information and general ledger information? And so I think it's important, and I appreciate calling out that the not fancy formats can also work, and you can still use those to actually get to analytics, to data that can help you make decisions. So I'm glad that you focused on that and called that out.
Yeah, and I would say the IDD industry are certainly not the only ones who do that, for sure. I can tell you absolutely. But yeah, there's a lot of that data out there. And the next slide, here we go, talking about data warehouse. Like, this is the optimal way, right? But if you think about it, well, let me explain what we do, and then I'll talk about kind of like other options, right? So optimally, what we would do is take all the data from those sources and put them in there. Now, if you guys are doing that at your agency, it's going to require a lot of people, a lot of time to really cull that and put it all together, because just like Jennifer said, a lot of times what you have to do is you have to, you could have different, IDs for each client in every single system. And so you got to link those up and figure out, okay, who's who, because I got to see them in all the different systems. Same thing with staff IDs. Same thing with, all the other assessments and things like that, because maybe half of your assessments are over here and half of your assessments are over here. And so one of the reasons that we do what we do and bring it into one data warehouse is, and Jennifer used one of my favorite sayings, which is a source of truth, is to be able to bring it into one place and have everybody in the organization, your finance team, your executives, your clinical group, everybody, even your outreach, right? Even your outreach, and everybody using that and marketing, using that same data and being able to answer questions and help each other out. So optimally, and what we do is we bring those data in, we put it in a central location. It's obviously secure. Our preference is to grab those data at least daily so that the data is as fresh as it can be. So everyone comes in first thing in the morning and they get the stats from yesterday and they can see the flow over time and how things are changing. We'll talk about the KPIs and how those are monitored too as part of this process. But it's really that transformation to ensure accuracy and meaningfulness that's really important. And one of the reasons that a warehouse and a partner who can help you with that warehouse is important is because often when you run a report, you're filtering it and you're cleaning it for that report, but it's not retained for future reports always, right? And so someone may run report A and someone may run report B, but they're using different terms or different values or different filters. And so it becomes a little bit hard to make sense of it. So being able to have it in one place where you're using a single filter across all the sources becomes really super helpful. But of course, if you're on your journey and you don't have a single warehouse, it doesn't mean that you still can't answer these questions. You absolutely can. It just may take a little bit more time, to parse and put everything together, of course. Static reports and business intelligence dashboards, that's the piece where we're trying to get the data out. That's the true analytics, right? The analysis of it. But what we talk about is kind of breaking it down in different components, because a lot of you are probably at the descriptive level, which is fantastic. Getting census, getting service utilization, so you know how many and what, so you know at least current status, and maybe you're trending and tracking over time. But one of the things that is beneficial about analytics is to get to the point where you can actually be diagnostic. So you can actually say what happened and why. So why did the service utilization drop last month? Oh, okay, we had a couple of kids that actually had to go into inpatient. And so that's why, or, whatever it is. And so you can actually answer and understand. And you also can see immediately those trends and how they're different from last month, from last year. But in particular, moving towards and getting into predictive and prescriptive analytics. So predictives are when we can actually use the data to tell us what is going to happen, right? So that is true statistics where we're saying, okay, utilizing all this data, what's the trend and what are we expecting in terms of net collection, in terms of census, for the next 6 months. But then prescriptive, one of the things I know clinically, sometimes we're a little afraid of this, but it's recommending what's possible. But the reason it's good is if you think about it, each of your organizations has a standard of care for your subpopulations. And so being able to see that and know that a clinician can actually, or, individual, provider or day hab person can look at it and actually say, oh, well, yeah, that is what we typically do, but this individual needs something different. And they still get to use their clinical judgment on it, but they know whether or not they're differing from that kind of prescriptive standard of care. So all of these things become really useful with analytics and statistics. Jennifer, anything you want to add to that one?
I would just say that this is the point where it starts to get really fun, where once you can answer some of these questions and you have that baseline of the descriptive and the diagnostic around, the counting, and then being able to figure out why things changed or why they are looking like they're going to change, that's really where you get to the point where you can start to make decisions about the future. You can start to say, based on what I'm seeing, I think we need to expand that program, or we need to make some changes, or we're really starting to see the data is showing us that the types of children who are being referred for this program are really changing diagnostically, or we're getting a lot more demand in this other program. And so when you start to have all of this information in that one centralized warehouse sort of model, and you can actually put together your financials and your payroll and your electronic health record and your outcomes and all of that, that's where you start to be able to have that sort of bigger picture insight into not only how to better run the business, but how to make better programmatic who are coming to you today for services.
Great. Thanks, Jennifer. And then, so I'm going to go through the next one really quickly, just because it's a brief overview, but I really want to get to the case examples and let Jennifer, really dig in. But just to kind of show this a little bit more of like hinting at the roadmap from the very beginning. And Jennifer will talk about this in her case examples. But first and foremost is confirming what KPIs you need to measure and start monitoring. Sometimes they're predefined by the payer. Sometimes they're predefined, by your industry or by your state or something like that. But most often it's what's important to you and what do you have access to, right? So that can kind of lead and inform that a little bit. But the second one, I think not everybody pays enough attention to, and that is that a lot of times we train our personnel at the highest level to look at these KPIs and keep track of it, but we don't bring it all the way down to the individual provider level and the individual program level. So training key personnel across the org on those role-specific KPI dashboards and making sure that they have bookmarks and filters that are appropriate so they can get to the data they need every day to take action is so critical. And I know Jennifer will share some of this because it was some of the biggest successes that I think Boundless saw was when they were able to cater to some of those specific needs across the org. The other piece is monitoring that status on a regular basis. And then of course, this fourth one is kind of obvious to everyone. If you're doing good on a KPI, great, keep monitoring it, but if you're low performing, it's that diagnostic. Well, why? Why are we low performing? Jennifer said, do we need to do the X or do we need to do Y? And then how do we create an initiative and kind of get people engaged and involved in actually making change in those areas so that all of your KPIs are either high or are trending in that direction? And then, of course, reviewing that progress quarterly. A lot of orgs use that as, our board meetings, so it's like every quarter we meet with our board and we show them. But even if you don't, having interim meetings with each program or, across each service line, whatever is most appropriate, I think is really useful. So now we'll go into the case examples and kind of walk through some of these steps. So Jennifer, I'll let you take it from here.
Thanks. And Missy, if you don't mind, if you want to go back to the picture there. Yeah, perfect. Okay. So the one thing that I wanted to comment on is I don't think KPIs are probably new to anyone listening. And the reality is most organizations have some sort of KPI process, but it may currently be on paper. So I want to talk about a couple of examples of how sort of changing to a format where we had all the sources of data coming in together has made such a big difference. So I don't think we were doing anything special. At the end of the month, you review your financials. And so as a program manager or as a program director, the expectation is that you're looking at how is your program doing on revenue? How is your program doing on expenses? And you're trying to make sure that the top number is bigger than the bottom number. And so we had a program, and it was in-home ABA services for children that we could not get to be profitable. And that made absolutely no sense to us because it was not a lack of children with the need for in-home ABA. It was not a lack of parents who wanted services. It was not because we didn't have people doing great quality services. And so when it was just, hey, this manager gets her financials every month and looks at it and tries to figure, okay, well, what am I going to do about this? We could not get traction. We were just in this same cycle, in the same loop where we just couldn't figure out how to get over that hurdle. Well, as we started to implement analytics where we're pulling together the financial information, but then we're also pulling in payroll information. We're also pulling in information from the EHR, which happened to also have intake information in it with information about what the parents were requesting and what was the initial referral, what was it that people were looking for. And that was when we came to realize it wasn't a lack of demand. It was all the demand was at the same time every day. Every parent wanted to have in-home ABA between 2 and 6, Monday through Friday, because the kids got home from school, parents were getting home from work, could be there to monitor, could participate, and so they all wanted it at the same time. Well, most of us don't want a job that you only work from 2 to 6, Monday through Friday. And so we realized that by having all of this information now being pulled together and being put in front of us in a different way, we could pull together other people throughout the organization, including some other programs, who were able to volunteer and say, actually, I could use someone in the mornings who has ABA experience. Would you mind sharing a position with me? And so that really helped us to think creatively and differently and out of the box when we had the information presented to us in a different way and that had more pieces of the picture. We could see a much more clear view of it and have a much clearer understanding of what potential solutions could be. I think another one is, for years we had KPIs on Excel, but the problem was that each director had their own Excel file that didn't get shared until the end of the month. And then it was after the fact, I'm showing you what happened. And so you would potentially have a month where, again, there was demand, there were referrals, but attendance was low for a week or for 2 weeks out of that month. And it had nothing to do with demand. It was because maybe my van was in the shop, or I had more staff than expected out sick. And because I was the only one who had that spreadsheet as the program director, no one else was seeing in real time what was happening and potentially offering solutions. Well, once this became a shared data warehouse with an analytics platform on it, and you could see it in real time, then it became really clear of, hey, so-and-so's attendance has been down for the past 2 days, and that's not typical. They have lots of people who need those services. What's going on? Someone could say, well, it's because their van is in the shop. I have an extra van. We could send it up to that part of the state and they can use it. Or they have a whole bunch of people all got the flu the same week. I have staff who want overtime. I can see if they want to travel to that part of the state and staff the program for this week. But having the information in real time, like you talked about, Melanie, is so life-changing, where you're not waiting till after the fact and looking at the spreadsheets at the end of the month and going, well, darn it, I wish we knew so-and-so's van was in the shop. Or, gee, I wish we knew that team needed a morning staffer and you needed an afternoon staffer, and we could have staffed it with one person. And so the kind of insights that, again, seem pretty elementary, maybe even rudimentary, that you can come to just by bringing the data into one place have really been transformational for our organization. So I just wanted to call that out, that this isn't rocket science for the most part. This is the opportunity of having all the information in one place and being able to see it in a new way and to make better decisions.
And if you guys aren't getting the undercurrent of what Jennifer is saying, it's so true because it's collaborative. They are so collaborative with this data. It's not just that it's in one place, but it's everybody has access to it. And so that's where it's like, you've got beautiful, like, I mean, she's got, this organization is amazing people top to bottom all over the place, but they are just so creative in their problem solving. And so everybody wants to help. Hey, like she said, what do you need? But it's not just in one place, but it's everybody looking at it and being incentivized to help each other, because, you know, everyone helping each other gets, you know, better outcomes for everyone. So I love that about your org.
Yeah, I always, one of our fundamentals is blameless problem solving. And I think it's my favorite one because I really do think that it's very entrenched into how we approach things. And I think that's really critical. And you've mentioned this before, Melanie, that you never want data to be a weapon because then people won't use it. People will, doubt it, or they'll say, well, I don't think the data is right, or I challenge it. And and then it becomes unusable and it's a culture thing. And so it's really, really important that the data is out there as a tool for all of us to work together and use to solve problems, not a weapon, not something to beat people over the head with, you have bad numbers. Okay, let's get together and talk about how we get better numbers then. So I do think that that's an important piece of why it has been successful for us, though. And you can
And I,
go to the next one, I think, Missy, because I'm going to talk about some more examples as we go through it. Um, so, Melanie, I'll let you talk a little bit about optimizing revenue and then fill in with some thoughts and examples there.
Sure. And Jennifer's got some great, so I'm going to do this quickly because she's got so much rich stuff to talk about. But one of the things that you guys know across our industry, my goodness, especially if we're talking about Medicaid, is that we have to have really strong billing processes and monitoring because there are so many things to monitor. And so if you think about it, if you are going to electronic billing and you are actually using it in your EHR, there's a lot of rules to set up. There's, it's like, how do you properly use that billing matrix? And how do you make sure that you know about pre-serve, like kind of pre-billing edits that are needed? And then also, how do you take in those 835s and those claims? And how do you process the denials? And how do you know how to adjudicate it, and those pieces? And so talking to, and Jennifer will talk about this, like talking to the vendor and making sure, and when we talk vendor, we're usually talking electronic health record vendor, but it could also be that you're doing outsourced billing with a group like SimiTree, but talking to them about that because they are a billing expert too. And kind of how can this be best done? How do we make sure that we set this up from the get-go so that we are utilizing everything available to us to make sure that we optimize this process from start to finish. And I'm talking start from like eligibility, right? So from insurance eligibility and waiver eligibility, all the way through to full adjudication of the claim and payment. So setting up that EHR or whatever that system is that you're using for payment is going to be really critical. And then, of course, supplemental processes that are needed or alternate setup that might be needed that could impact billing or clinical programs. I'll let Jennifer talk about this, but sometimes each of the programs have to have other components that might have to be outside the electronic health record that they're monitoring and evaluating and taking care of. And it might be technically in the EHR because it could be a form, but it might actually also be outside. But knowing that there might be these supplemental processes or alternate setups that'll be needed per payer, per coverage plan, per type of service, those are things that are really important to know, and not assume that you are absolutely limited by the features in your electronic health record, to know that there's other opportunities available for being able to monitor and process. So on the next slide, Jennifer will talk a little bit about contracted rates and things like that.
Yeah, so one of the things that I did want to mention that you were talking about this, Melanie, is everyone's heard the phrase garbage in, garbage out. And so it really, I think, speaks to your prior slide of it is so critical when we're talking about optimizing revenue to do the work ahead of time. Honestly, and I think that goes much faster now, but when we were going through the process of figuring out cost of service, I think it took us 14 months of answering questions of just figuring out, okay, well, in a direct service, does this general ledger code go here or go there? Well, why does it go there? Well, why did we set it up that way in the beginning? And honestly, as we went through this process to be able to develop dashboards that would be meaningful and usable, we actually realized that there were a lot of things that we had set up in our EHR originally that we wanted to go back and change because we were going to have much cleaner, much more usable and informative data by making some setup changes. And so I think that that is so important for anybody who is either going from paper to electronic record keeping or paper to electronic billing and formats, or from one electronic system to another. Really, really taking the time to ask a lot of questions about setup and asking questions about, well, the way we do it now is this, but it's because of this within our paper system or this one staff person who does this one thing on Tuesdays. It's not because this is how it has to be. And so I think taking the time to make sure you're actually optimizing how the information is getting in, how it's being recorded, and then how it's going to get pulled out is ultimately going to give you much better data on the back end. And so one of the dashboards that we spent a lot of time on were questions like, are we getting paid what we are contracted to get paid? And we started with things like, okay, now we have answered all these 14 months of questions. What does it cost? What are we charging? What is our usual and customary rate? For this contract, for this payer, for this person, what do we think we're gonna get paid? And then what did we actually get paid? And so I'm not sure if you have one of these dashboards in here to show, but it actually shows up as like all different columns. And one of the things that we found out was that there were scenarios where cost was higher than what we were even charging. So there was no way we were going to break even, because even if they paid us exactly what we had contracted and we had 100% net collection and we were killing it in our billing department, we were still going to be losing money because we weren't even charging what it was costing. And so I think that that really was an eye-opening experience to be able to go through all these processes and figure out how do all of these things stack up and line up. Now, there might be times that you know that and you choose to do that for other reasons. Maybe it's a loss leader, maybe it's really mission critical, but you can't do that for all services. And so making sure that you're really clear where that's happening and that that's a choice, not just something you didn't realize was happening.
Yeah, and I'll add too, we do have some on the costs that are coming up in just a moment, so you might be able to highlight some of those. But one of the things, that I think is important too about what Jennifer's saying is, this is not just for fee for service. Some of the other stuff that Boundless does is, of course, grant based. But what they still do is they make sure to put the actual services provided, even though they're not billable in the EHR. And then when it came to the cost, they were able to marry the grant, the grant numbers. And actually now they actually, I think, have the grant payments like in the EHR, but at least even if it's just in your GL, when you marry those two, that's the best way to evaluate cost, because now what did my providers actually do? What did my clients actually receive? And what was that bucket grant related or per diem related, kind of cost that I got that maybe didn't have to get billed? And so that was a really eye-opening thing, I think, when you guys were able to see all the non-billables, that
Yeah.
kind of worked in. And when we say non-billables, right, it's not fee for service non-billables,
Right. Mhm.
um, but yeah, it was super eye-opening, I think, right?
Absolutely. And I'll be real honest, I actually was unaware of how much of the revenue for certain programs was actually coming from either school districts or other grant type sources and things like that. And so then being able to sort of line up, like you said, what are the services that are getting provided with that bucket of money, and what did it cost to provide those compared to what that contract or that grant or that waiver, whatever it was, actually uh, had in it. So definitely informative. And then on the waivers, you kind of referenced this a little bit earlier, Melanie. This was a set of dashboards that we built because we do provide a lot of waiver services. And so we worked with AFIA SimiTree to be able to monitor the waivers of what was the amount that was authorized, and then what is the amount that has already been spent, and where are we in the authorization period, so that we could be really clear of we're almost to expiration and we're exactly where we anticipated being at this time in the year, and the person is getting the units of services, the types of services, the amount of services that they should be getting, and we are right on track. Or we're really overspending. What is going on? Do we need to contact the payer or the county or whomever and let them know that either the need has increased or something has changed and they're needing a lot more services than what was authorized or what they expected to receive? Or we're almost to the end of the authorization period and they haven't spent a lot of their allotted money. Presumably, that means they didn't get the services that they were supposed to get. So why did that happen? And what do we need to change? What needs to be done differently to make sure that that doesn't happen so that people are actually getting the services that they're supposed to be getting? And so it certainly is monitoring overutilization, but just as equally underutilization and making sure that people are getting what they need to receive and that we're on track for what we expected at this point in the year. And this has been really, really helpful to help us be able to monitor this across thousands of people and thousands of waivers.
Yeah, and this is an example, by the way, of a different data source that we had to use and grab. So this is completely different than their primary EHR, but it's in the same dashboards and the same set of data, so they can see it with other data, which is really great. And I realize we have so many great stories. You talked about cost a lot, so we may fly through the next three pretty quickly, but I really want to get to those outcomes because I think that what they did with those was fascinating. So I think this one, you pretty much talked about these. This was the column you were talking about, right? Of being able to renegotiate, educate payers. And I know you have a specific story that you were able to increase, right?
Yeah, actually being able to take our cost data and go to a payer and explain, look, this is what it's costing to deliver this particular set of services to this population, actually allowed us to negotiate higher than standard published Medicaid rates for the services. But, and this gets to the outcomes piece, which I know we're going to get to in a minute. The other reason that we were able to do that is because in our dashboards, we could also show that being engaged in our services over the course of the prior year had markedly, and you could see it in the data, reduced the number of times that the children were hospitalized, had reduced the number of times that these same children had visited the emergency department. And if they were hospitalized, they stayed in for far fewer days. So when you can take that kind of data to a payer and say, look, it's costing us more than you are offering to pay us to do this service, but let us show you what the data shows over the past year that we've been able to achieve with these services. It was a no-brainer for the payer to say, yes, actually, we'll agree to an enhanced rate and increase the contract. So even above sort of that flat Medicaid published rate. So that's very exciting when you have that kind of data and can go and can say, here, based on real numbers and real information, let's have a real conversation.
Yeah, absolutely. And even I know you've on a couple of occasions used your data with other organizations and gone and talked to policymakers as well, I think. So yeah, absolutely. And I think this one we already talked about a little bit, but this was the idea of like, what if they change the requirements on you? What if they're not going to reimburse for a particular type of supervision? Can you look at it and see what's it's going to cost you when you change it? So I think that was really important. And then the next one, I think, was just Jennifer was mentioning this, like, why in the world does it cost more, right? In like this one location. So I don't know if you want to talk a little bit about that one.
Yeah, it's a funny thing that was came to light right in the very beginning when the dashboards first started going into use, of trying to understand, why does it cost more to provide counseling at this location versus that one? Or why is it cost more for nursing services in this part of the state versus that part of the state? It's the same kind of program. And sometimes it's because there's a staffing shortage in that part of the state that another part of the state doesn't have, and so we're having to pay a lot of overtime. Other times it's, hey, there's a really terrible lease negotiated at that particular building, and the occupancy cost is just higher. Other times, maybe staff have been out or there's been turnover, and so supervisors have been filling in. Supervisors cost more money. So their hourly rate is going to increase what it costs to do the services at that location for a period of time. And so sometimes there's an action that needs to be taken. Sometimes there's not an action that needs to be taken, but at least you have the information to be able to make that decision of saying, it is costing us more to do the exact same service here versus one block over. That doesn't seem like it should. So what's the difference? What's going on? And do I need to do anything about it? Or is it going to resolve itself? But at least you have the opportunity to ask the question.
Yeah. And the shared understanding across the organization. Absolutely. And then I think the next one, this is like my favorite, right? The outcomes. And the reason I wanted, Jennifer to get some time to talk about this is, we talked earlier on that little slide that had all the columns of what to measure, what data is available, will it have a positive impact on client lives, and what interventions can actually impact the outcome, and are we already doing them? So Jennifer's got a great example to talk about for us of one of the outcomes. So if we go to the next slide, we can actually see that part of the decisions they made, I think BMI became an important one, if you want to talk about that one.
Yeah, and for all the reasons that you just talked about, is we have lots of lofty ideas and delusions of grandeur for the future. But we needed to start with what's data that we already have, what's data that we think we can do something about, and that we think if we did something about it, it would actually impact people's lives. So we started with BMI. And so first we had to figure out who was measuring it and how is it defined? You would think that this would be an easy answer, but we realized that different parts of our organization were measuring things at different intervals, recording it differently, putting it in differently, recording weight but not height, all sorts of things like that. And then who's going to measure it? When was it going to get measured? And did we need to measure at different intervals based on whether the person was at a healthy weight or an unhealthy weight? And then where was all the information going to go? And I do want to call out, because this is an opportunity for learning that you can skip some of our mistakes. We originally had the idea that all of our direct service professionals and our QIDPs were going to put information into an EHR that they did not use day to day for the rest of their services. And you may be able to guess that that did not go well. And so they were not putting the information in the EHR, no matter how much we reminded them. So ultimately, we gave them a spreadsheet. We gave them a forms, essentially, that they filled in the information there. And once a week, we would go sweep it out of this form and put it over into the analytics dashboard and actually create the information based on that. Now, they were more than happy to record the information. In fact, they had been recording it all along. They just didn't remember how to use this system that they didn't use day to day. So they weren't going in and putting it in. And so I think that's a really good example of making sure, as Melanie was talking about early on, that you are paying attention to who the users are and that you're getting involvement and you're getting buy-in from people at all levels to actually make it usable and make the data something that people are going to see meaning in participating in.
Yeah, and Jennifer mentioned one thing which was really interesting. So you remember she said they're calculating weight or they're putting weight in, but they're not putting height in. And they were kind of like, well, they're adults, their height's not changing. We said, you know what, you're right. So we created logic to say, hey, if they are over 18 years of age and we have a height in the recent year, or whatever it was, just use it and calculate BMI. And so we also agreed with them that they didn't need to do redundant data keeping, for that purpose. And so we worked with them and created logic. So that's the other thing, is make it easy on them. So go with their workflow and how they want to enter it, but also don't make them enter extraneous stuff that you have elsewhere and you can actually utilize that data from another place. And so the next slide kind of shows kind of how we were monitoring it. So we have a population health monitoring product. And so BMI is one of those. So Boundless was able to see kind of, number one, was there an observation effect just by measuring it, right, Jennifer? I know you told me a neat story.
Yeah. So one, there was an observation effect. As soon as we started asking people to record it, we started seeing the outcomes actually change even before we had implemented an intervention. So that was very interesting. But then once we implemented the intervention, it had to do with the stoplight diet, which is really just categorizing food into different color categories and giving people the choice, not mandating, giving them the choice and the education about choosing the bucket they wanted for that meal or that snack. And then using CDC guidelines around exercise. And again, giving people the choice and making sure we were offering, letting them respond. And we started to see incredible outcome, like true change of people moving from obese to overweight, from overweight to healthy, underweight to healthy. So we really started to see some great outcomes. And that was very, very exciting. And I'm not sure if you have it on this slide, but I also always share the learning opportunity in this. So this was going fantastic. It was adults in residential settings, really good outcomes, really excited about it. About 8 months later, I was at another residential setting, served youth, northern part of the state where we had not done this pilot. And I go in and I see all of the materials hung on the walls in the refrigerator. Oh, that's fantastic. You're implementing the stoplight diet program. And then they're like, oh my gosh, it's amazing. Like this young lady has lost so much weight and this young lady is so much healthier. And this staff person started doing it. They lost 40 pounds. And that's amazing. You guys are recording all the information in the portal. And every single staff person in the house looked at me and like, what? Putting it where? So somehow they had adopted the practice, which was wonderful. They were getting great outcomes, but none of the data was actually being recorded and captured and put in. So this is, I think, back to, I think it was number 4 on your KPI process, Melanie, of keep monitoring, keeping coming back around to make sure that we're continuing to gather the data, we're continuing to make sure that all of the information keeps getting into the outcomes and we don't lose our traction as we get some successes.
Absolutely. And again, just with the logic of it is that we didn't make them think, right? So they didn't have to say, is this change improvement? Is this regression? How is it compared to baseline? How is it compared to last time? So all of that was also automated in this process to be able to see that. And because we're so short on time, I just wanted to move real quick to the analytics roadmap. I'm not going to walk through all of these, but just, we'll give you guys copies of this so you guys can look at it, but just kind of questions to think through. It kind of summarizes the pieces that we've been talking through. And again, the last point I think is so important. And Jennifer mentioned this from the beginning of just live where you are right now, build slowly, and maybe it's only in one program that you're actually collecting more data or using the data, but I think it's right. Live where you are, kind of utilize and make sense of that and kind of move from there. But Jennifer, I'll let you make any last comments that you want to, and then I want to see if there's any questions.
Yeah, the only thing that I would comment on is that in all of this, I talked about how it took, lots and lots of months of thinking through and building and all these technical, amazing things that AFIA helped us do. At the end of the day, the really hard part was actually the culture change and the adoption with staff of moving to being a data-informed organization. And so I just want to stress making sure that you're giving enough attention and time to that cultural shift and really putting the necessary investment and explaining why to staff and how this is going to positively impact the people that they care about and the people that they're serving every day. So I don't want to lose sight of that piece is possibly even harder and takes longer than all of the other stuff that we've talked about on the technical side.
Yeah, you're not kidding for sure. Yeah, that's good. So I know Missy, you're going to ask, but any questions that anyone has that we could answer? Or maybe I can ask you guys a question. Where is everybody on their journey? How many people do we have attending that are like kind of starting on the journey, kind of mid journey?
And one of the things that I'll also offer, I know sometimes people think of questions later, and I'm always happy to answer questions after the fact, or if there's questions that people think of or people want to hear more about all of our mistakes, I am happy to share those. And I do appreciate, Missy, that you put contact information on there too. So if there aren't a lot of questions today, I do want to mention that I'm more than happy to answer questions after the fact too.
Yeah, 100%. Both of us are available after. And I can't tell you how much we've really appreciated working with Jennifer and I Am Boundless, because we've learned so much from them, just like they've learned, from the system that we've given them. So, again, feel free to ask questions. We'll be happy to show you guys the range of products that we have and how we can bring data in. But thank you so much for joining us today. And again, send us any questions you may have after.
Thank you.
Oh, Missy, I think you're on mute.
I am. I was saying thank you, Jennifer and Melanie. What wonderful information you shared today. As always, reach out to us if you have questions. We can't wait to see you at our next webinar. Everybody have a wonderful day.
Thanks. Thanks, Jennifer.
Thank you.
Thanks, Missy.
Thank you.